This contrast MRI shows the presence of an inverted papilloma on the right side. One can see the presence of an already done medial maxillectomy using Denker's approach. This young patient, has been operated 4 times in the past for an inverted papilloma, and the last biopsy or the histopathology reveals a full thickness dysplasia in the lesion amounting to carcinoma in situ without involvement of basement membrane. So this alerts us to the fact that we need to be much more radical about this procedure and this patient. She's a young patient with 4 previous surgeries, the last one being an medial maxillectomy using Denker's approach, but we still see, as you see in the endoscopy and the MRI, presence of papilloma in the lateral nasal wall and the roof of maxillary sinus. The ethmoidal cavity appears to be clear, so is the floor of nose. And this time we want to make sure that we do an en-bloc excision for this lesion along with exhaustive drilling of the surrounding bone without preservation of the inferior orbital nerve. Now, we know that this carcinoma in situ in a young patient can surely progress to frank malignancy, and this appears to be an important chance and opportunity to resect this en bloc and not in piecemeal, because we do not want to leave any portion of this lesion inside the nasal cavity. The frontal recess is clean, as you can see. The ethmoidal cavities are totally clean. So after mapping this lesion, we use a coblation probe wand to first keep our margins, and that would be approximately 0.5 centimeters to 1 centimeter somewhere around the lesion and not violating this lesion. So with the coblation probe, we are planning our margins all around the lesion to be very, very sure that we resect not only the lesion, but a fair amount of mucosa and bone around the lesion endoscopically radically, so that we avoid any further recurrence of this lesion that has been there for quite some time because of most likely inadequate surgery. So despite being carcinoma in situ or a full thickness dysplasia, this still remains limited disease, but is borderline malignancy. And it's very important to resect this with a different mindset as compared to how we do for a routine inverted papillomas, where we remove them piecemeal or in a multi-block way. Since this is not very extensive, we get an opportunity to remove this en bloc. It's always better to give not just a complete marginal excision with this patient, but also an opportunity for the pathologist to evaluate the specimen en bloc and not in multiple portions, so as to conduct an exhaustive study on this lesion and see in case there is any basement membrane invasion or conversion to a full malignancy. One may plan to radiate this patient in the postoperative period. So you see how we are mapping the margins on the floor, the posterior aspect of lesion, and mapping all around with a generous amount of normal looking mucosa, so that any microscopic margins are completed. And once we have done it inferiorly, superiorly, posteriorly, now we do it anteriorly at the exact piriform aperture, which already has been once operated, but now we go slightly even more anterior towards the vestibule. Now that may lead to a certain amount of scarring, but then that is all right price to pay when we are operating a borderline malignancy and multiple times operated patient. Now, if you see, what is very important here is that we will be constantly drilling and going lateral to the lesion to not leave anything inside the lesion attached to the bone. And once the lesion is removed en bloc, then we would resort to exhaustive drilling of the entire base, which we will have, which we have marked using a navigation probe, and we will constantly mark it during surgery as well as after surgery with a navigation probe to see that we have resected a fair amount of bone around the lesion everywhere. So you see how we have once marked with the coblation, we have ablated the mucosa, come to the bone, and then we start drilling the bone lateral to the lesion. We are not using any microdebrider or coblator on the lesion per se. And here we are using a coarse diamond burr to constantly drill lateral to the lesion, so that we keep exposing or identifying the base of lesion, and we plan not to violate it for as long as possible, so that the excision remains en bloc. Sometimes it may not be possible to remove en bloc, and that is fine. one resorts to multi-block or a progressive resection. But wherever possible, an M-block resection is hugely advantageous because it gives us an opportunity to be more precise as well as give a better specimen for pathological orientation and also margin submission. You see here using a suction elevator which is slightly curved because we need to go laterally, and our instrument must not go medially because then that will puncture the lesion. So to avoid puncturing, we go step by step slowly, laterally and superiorly. The goal is to go right to the floor of orbit, and in that case, even if we expose some amount of periorbit, that is quite okay, and that is what our game plan is. Here you see the lesion is now being pedicled onto the nasolacrimal duct. It is firmed, the NLD is firmly attached to the bone here, and we are elevating it, again drilling laterally and superiorly to it. The last time we saw that in the previous medial maxillectomy, the superior aspect was drilled inadequately possibly, and that is where most recurrences will initiate at the site of nasolacrimal duct or the orbital floor. These are most common recurrences in these lesions, sometimes even lamina papyraceae. So you see here how we are taking a little bit of time in constantly drilling lateral to the lesion and detaching this lesion from the bone around, followed by what we will do is eventually drill all this bone off to be very sure that the initial markings that we had done with our coagulator is maintained at the end of the disease resection. So you see here that we are still in still the posterior margin, inferior margins are quite well visible to us. The superior and anterior margins have been used to progressively elevate this tissue, this pathological tissue from the bone. And you see now that each time we elevate some bit of this, the lateral visibility goes because there is more bone. So what we do here is a mixture of these articulated punches sometimes, as well as the curved drills to keep resecting lateral bone, so that you keep having visibility lateral to this pathology in between the bone, and you can elevate this without causing any big tear inside this. Use of a curved elevating curved suction elevator is of huge help in this step, because a straight elevator would practically puncture this much earlier. And you see now how thick ridges of bone are occluding our vision, and how now from medial maxillectomy we are literally going toward the subtotal maxillectomy, drilling off almost all the anterior and initial part of the lateral wall of maxilla, just without the palate, to be able to be sure that we do not miss any diseased bone, and we are able to remove this entire papillomatous tissue and block. So you see here we are progressively drilling onto the anterior, lateral, and now superior wall of the maxilla, that is the floor of orbit, to basically expose the nasolacrimal duct in its entirety before cutting it flush with the orbital floor. Now you see how more elevation has resulted in a far better exposure. We are able to see better our lesion, which is now pedicled more or less laterally and slightly posteriorly, and also on the nasolacrimal duct. Now that we know that we can see the some bubbles coming out of the nasolacrimal duct, and as we keep elevating it, you see how that in between we also use the help of a curved cautery to keep resecting the excess mucosa, which teasers this lesion posteriorly. So as we do that, we use some sharp and then in between some blunt dissection, and now we see how we are peeling almost all of it from this wall, and I think just the pedicle now on the nasolacrimal duct. As you see here, this entire pathological lesion, or this papillomatous lesion, which is of full thickness dysplasia, has now been completely removed from the bony maxilla walls. And what we are now debriding using a curved debrider is just some excess redundant mucosa which we want to remove, because we want to expose bare bone hair for further drilling, especially on towards the inferior wall of the orbit or the superior wall of maxilla, which was the attachment site apart from the nasolacrimal duct. You see here we are spending some time on the nasolacrimal duct because we want to remove all possible bone before we actually get to transection of this duct, and so that again all of our specimen is removed and blocked without anything left on the duct. So you see here how we keep drilling on the superior wall. The goal is to come to the orbit and to expose the periorbitum, the periosteum or the periorbita briefly, so as to be sure that there's no bone left superiorly as well. So you are drilling laterally, as you see, drilling superiorly as well as in a brief file posteriorly as well. Our entire lesion is now lying pedicled on the nasolacrimal duct, as well as maybe slightly posteriorly, which once the drilling is completed on can be just simply transected. Now you see how once we have defined the NLD, we try to give a sharp cut onto the NLD and to remove this lesion in toto. So as we keep doing that, means we are seeing that some bit of it is still attached. So we keep a little inferior tug onto the lesion so that we don't miss any of it superiorly. And along with that inferior tug and an inferior push, we keep transecting the superior part of the lesion as well, on which there is still a fair amount of mucosa because of the margins that we took in the beginning of surgery. As you see here, posteriorly towards the maxillary mucosa, we keep resecting this tissue off. And now you can see here how our specimen is barely pedicled onto the slight amount of maxillary mucosa and is ready to be taken out. Now that's our entire specimen, which has been removed, with now leaving us a larger maxillectomy cavity, cut nasolacrimal duct, as well as some redundant mucosa which has to be removed, followed by exhaustive drilling of this bone so as to be very sure that there's nothing left behind in terms of the bony attachment as well. So we get back to drilling, and now we are drilling off the roof of the maxillary sinus, the orbital floor. You want to make it totally flush with the floor of orbit so as to expose the periorbita at places so that we know that we have practically removed all amount of bone possible and not left anything for any possible recurrence this time. And if you had noticed in the MRI as well that a fair amount of disease was apparently right on the superior wall of the maxillary sinus or the inferior wall of orbit towards the nasolacrimal duct, and most likely also towards the approximate location of the infraorbital nerve. So when we have already known that the carcinoma in-situ kind of pathology is there and full thickness dysplasia, I think even if we have to, be aggressive on the nerve as well or on the region of the infraorbital foramen, I think one mustn't be too scared of that, because disease serance here in a young patient is of primary concern and foremost concern, and everything else is possibly secondary. In a younger patient, this has a serious risk of conversion to a full malignancy, and as you see here, the entire roof of maxillary sinus right flush to the orbit is now being drilled. No ledges of bone now are planned to be left behind. So we see here we are drilling the bone all around, medial and lateral to the infraorbital canal, so that we know that every bit of bone here has been drilled to our satisfaction. Now, this was most likely the base of the tumor, and this is the bone that we intend to drill even more extensively to be very sure that despite the fact that we have removed the entire papilloma en bloc, we do not want to take any chances with this diseased bone, and you want to drill this even more exhaustively. You can see how now the cavity looks far better as compared to what it was, but we are not done yet, and we would be drilling even more to get clearance of this cavity because you don't want taking chances this time, this kind of pathology. Here is a remnant of the medial wall, the posterior part, which houses the palatine nerves and the vessels. This is the posterior wall of maxilla. Our goal is to drill exhaustively to expose very briefly the periorbit of the intertemporal fossa as well as the orbit. So we know that the superior and the posterior walls have been drilled extensively. As we have seen, the lateral and the anterior wall already has been drilled out to satisfaction. So now this is the part of bone that we want to drill exhaustively, is to be very, very sure that no previous involved bone is even faintly around anymore for this disease to recur. These lesions already have a high recurrence rate, and when you're operating a patient who has been operated many times in the past, I think the need to it cannot be overstated how important it is to drill it like probably you would do in a malignancy, actual malignancy, and just the only difference being that you're doing it with a drill and progressively, and not through chisel hammers or a saw, how you probably do it in a usual radical maxillectomy. Now we are drilling onto the infraorbital canal as such, the bone over it, and we might expose the nerve also, but then we want to definitely be sure that the entire bone all around the infraorbital canal as well as on it is being completely drilled to our satisfaction, and you can see some amount of bleeding that normally is from the infraorbital artery, which is housed here and starts to ooze. So the infraorbital canal is now being cauterized and coagulated for management of bleeding. Also, we would not wish to leave any residual mucosa in this part of the bone at all. So we would be broadly coagulating any redundant tissue here. So we continue our drilling in the posterior medial part of the cavity superiorly. This is the bone that normally covers the pterygopalatine fossa. So we again conclusively drill this bone thoroughly. And it's, I think, very important to understand that even in primary patients, but much more so in revision surgeries, this bone drilling in even papillomas which do not display full thickness dysplasia is should not be casual or just a little bit. For personal satisfaction, it has to be really exhaustive and extensive to make sure that entire diseased bone can be clear, because often it is this diseased bone that harbors the maximum mitotic activity in these lesions and is most likely the sites of frequent recurrences. And you see here our final maxillectomy cavity is gradually taking shape. One can appreciate how different this is from the past cavity that one saw. We have gone much more laterally, we've gone more anteriorly, we've gone more posteriorly, and most importantly, they've gone more superiorly to be able to be conclusive, taking out all the bone all around the nasolateral duct, and well as the infraorbital nerve, because in a radical surgery, these things have no place. You see how even the most superior part of the maxillary sinus medial wall, just approximate to the orbit, is now being drilled medially. So once again, we are coagulating in the approximate location of the infraorbital canal, and the minor bleeders that we saw, for most part, our procedure is now complete with the definitive drilling of the affected maxillary walls, the lesion being removed and blocked, and we can see the final maxillectomy cavity in front of us, which is to our satisfaction. And what else we nowadays do in such patients where there has been multiple recurrences, we are using just some anti-vascular growth factor inhibitor antibody, that is the monoclonal antibody bevacizumab, is being now injected close to the nasolateral duct, so to avoid any possible recurrence of the papillomatous lesion. Use this for recurrent patients. This completes our surgery post placement of a surgical sheet for early healing of this region.